All right, so the acquired cardiovascular disorders, we're going to talk about some of them. Just will have their own video, and some of them we may put a couple in a video. But again, I want you to use latte. Okay, I want you to focus on the pathophysiology, what's happening, and then what are we doing about it? Okay, so infective endocarditis. What does that mean? That means an infection in the lining of the heart. Okay, an infection in the lining of the heart. All right, so who is more likely to get this? People who have either increased exposure, they have bacteria going into the bloodstream, or who have some sort of structural abnormality that makes little places for bacteria to grow. So think about kids who have some kind of structural abnormality of the heart or the great vessels, so congenital heart defects. Think about central line complications. Think about valve replacement surgery. If a valve has been replaced, it's got places for bugs to grow. If there's an artificial valve or anything foreign in the body, it's a place for bugs to grow. Also think about IV drug use when we get to older kids and adults, because that's a way that bacteria tend to be introduced. And people who are immunosuppressed. Okay, I want you to think about why each one of those is a risk for endocarditis. It's an infection of the inner lining of the heart. It usually involves the valves. In children, this has a 20 to 25% mortality rate. 20 to 25 mortality rate. So what happens is bacteria in the bloodstream settle and form clusters. And they usually settle on some place that has some sort of structural abnormality or some inflammation. But they're called vegetations or clusters of bacteria, fibrin, and platelets. They may invade, that infection may invade the tissue, and they may break off as emboli. So we've got these clusters of bacteria and stuff sitting maybe on a valve, and it can break loose. Okay. Diagnostic testing. Who would we think of? Maybe we need to test for that. What are some of the things we would think? So we look at clinical manifestations, which we're going to look in a minute. This is something that's easily overlooked. Blood cultures are done. They may do an echocardiogram and see vegetations. And this can lead to heart failure and to dysrhythmias. And so we might see heart failure, signs of heart failure or dysrhythmias. So what might this look like? It's usually insidious. It's not well and then suddenly sick. They may have unexplained fever. It's usually low and intermittent. They may have anorexia, poor appetite. Malaise is the feel bads, weight loss. One of the things that is kind of a classic presentation that you may see is in the nail beds, you may see splinter hemorrhages, these little red lines. You should always report those and say, hey, can we look at this person's heart? Osler nodes are red, painful nodules on the phalanges, the hands and feet, on the fingers and toes. Janeway lesions are painful hemorrhagic areas on palms and soles, so they look like bruises. Petechiae on oral mucous membranes. If they have a new heart murmur, or if they've had a murmur and it has changed, those are all things that should make you think, hey, I wonder if this person has endocarditis, and refer that to be for testing. And endocarditis can damage the valve. Okay. Medical management, this patient gets a high dose of an appropriate antibiotic for 2 to 8 weeks. They're probably going to be on IV antibiotics. They need blood cultures to evaluate, so they're going to probably get serial blood cultures. Cardiac function is managed. Now, to prevent this, some patients who are at risk may get prophylactic antibiotics, especially for dental procedures. but they may get prophylactic antibiotics for any kind of procedure that may introduce bacteria into the bloodstream. Now, the guidelines for that have changed. They've kind of pulled back a little bit. Some of the patients who used to get prophylactic antibiotics may not get them all the time now. But one of the preventive things is patients who have, for example, certain types of valve issues may get prophylactic antibiotics. Nursing care is education, managing those symptoms, catching this, observing, hey, what's going on, catching that they may have a complication, but we're managing long-term antibiotics, and coordinating information with other providers. This is lots and lots of communication, because this is an illness that kind of comes on gradually, and they may get really sick before anybody recognizes what's going on. Nurses do not diagnose this, but a nurse may be the person who notices things in assessment that lead to that diagnosis.